See what Dr. WAVIKAR has to say. In the meanwhile, can we just have a show of hands? How many of us are doing LRIs regularly? And how many of us are doing multifocal torics regularly? Okay. Yes, your presentation, please. It's not yet seen.
Good morning, everybody. Thank you, Dr. Anaga and AIOC for giving me this opportunity. So my topic is about LRI. I'll skip some of the slides because they have been explained very well by Dr. Nagavekar. So over here, our objective is to reduce the astigmatism. When we are talking about this small area of 0.5 to 1 diopter, what to do about this? A few years back, everybody was comfortable with 0.75 residual, but today the scenario has changed because there is a significant drop in distance visual DCVA when we don't do LRI or Toric, whatever. Now, I feel that Toric LRI is meant only for this range of astigmatism, 0.5 to 1, and of course, cost is. I'll come to the cost later. But if we leave behind, there are a lot of issues with astigmatism, and I'll skip this slide because it has been discussed properly. Now, we talk about less expensive. It is definitely less expensive. See, Dr. Nagavekar, why don't you charge for LRI separately? I charge. Then the cost, I recorded the cost of the diamond knife 1,000 years back.
1,000 years?
Yeah. I charge separately for the LRI. That is a secret. So, see, we can always charge separately because we are doing some procedure, okay? And margin for error is actually, it is not unpredictable. On the contrary, what I feel is that, if you put a toric IOL, okay, for a 0.75 astigmatism and patient is left with 0.5, it looks very funny. On the contrary, LRI, even if you go off by 5 or 10 degrees, you will be left with a 0.20, 0.14 diopter cylinder, which is clinically not significant. Unless and until you have got 0.5, we are not worried. So, on the contrary, I feel that for small LRI, small astigmatism, LRI is the way to go. Then we have got image guided system today because of which the accuracy has increased further. Okay, we can get LRI exactly by the degree. Then we have incorporated posterior corneal astigmatism, because of which again our accuracy of LRI has increased. Let us talk about dryness. See, dryness comes because we are cutting corneal nerves and they are entering the cornea from the periphery. But over here we are talking about very small LRI, 20 to 25 degrees arc, and if we can, because of femto, I learned them to place on a 8 millimeter circle. So 8 millimeter circle, they are very much inside, so the irritation and the dryness problem decreases. And at the same time, because of femto, they have become very, very predictable. See, one of the main reason about LRI being recurrent, the recurrence of the astigmatism, was that we were not taking proper incision. But if you see the diamond knives today, and if you see the femto LRI, you are going deep right from the beginning till the end. It is not like a shallowing in the periphery. That was the reason for relapse of the astigmatism. So because of all this, we are not getting relapse at all. And now, and who does not have dryness today? It is ubiquitous. Post cataract surgery, the incidence of dryness is supposed to be 91%. So where is the role of LRI? Everybody is getting dryness. It is our job to assess dryness perioperatively and treat them LRI or no LRI. Then stable and sustainable, I think we already explained this point. I am charging extra for LRI, that is one thing. They are more predictable. The relapse rate is much, much less with femtosecond. That at least you will agree. So I think overall for small astigmatism, rather than Toric, I would definitely consider LRI. And last point is that the learning curve is very, very less. It's very simple technique. It takes hardly 1 minute for one LRI. And nah, it is very simple. You come to me.
Thank you so much, Dr. WAVIKAR. I hope, was this the last slide? Okay, thank you so much. So today now we have a question. Now first of all, Dr. Anurag and Dr. V.C. Mehta, sir. Now if you are talking about, for example, yourself, if you have a one diopter astigmatism and you want a multifocal IOL in your eye, what would you prefer, a toric multifocal or an LRI? Both of you.
So I have stopped guessing what is going to be the residual astigmatism, where should I take an incision, and what would happen. Just as you calculate the spherical power of an IOL, also go ahead and calculate the cylindrical power. If it shows a toric, you do a toric. Very simple.
Absolutely. But if it shows a toric, would you still go ahead and do an LRI if it is...
LRI is thing of past. LRI is gone.
Truly, is it?
No, actually,
What is your...
it's definitely true that the addition of the femtolaser into the system and combining the paired arcuate incisions has probably resulted in a little bit of better predicament in terms of accuracy. However, in my hands, I'll definitely go in, let me give my verdict first. I'll definitely go all out for Nagvekar sir because of two reasons. One is even with variant-assisted paired LRIs at 8 millimeters, it doesn't work well in my hands, at least. It might be working very well in WAVIKAR sir's hands. I think the basic reason where it falters is 90% depth in different corneas yield different results. And what you do not have a hand on is the healing part. So even if it shows neutralization of that astigmatism immediate post-op, the drift always takes it back. Vis-a-vis that, since he mentioned that a 0.5 with a 0.75 residual cylinder at the spectacle plane, most probably you are going in for a T2 model in this case. And for a complete neutralization or complete failure of toricity, you need to have a 30 degrees rotation of the IOL, which is not very commonly found in the materials that we use nowadays. So the results are very stable.
So, Dr. Vavik...
And moreover, when you do an LRI, it might interfere with your sight.
Yes, so that
No,
we can plan it. We can plan that.
No,
so
it cannot be within the 30 degrees of the lateral horn of the LRI, but that's something variant tells you, so it just shifts your incision to some other place.
So, does it mean that one, if you want to do an LRI, you need access to a femtolaser?
No, not
No, not at all.
No, this we are giving
Not
just a
necessarily.
message. We are just, this is apart from the debate, we are just...
Ideally, yes, but
See, you require a diamond knife with, any depth possible. It's not a 500 and 550. That is a compromise. You require...
Calibrated, yes.
And then you go at 85% of the corneal depth, wherever you go to take it, and then it works.
but LRI, you are handling biological tissue. Your response can be different for while in
That's
That's
exactly
what
what
you
I'm
were
saying.
saying. So probably if the patient can afford, then toric multifocal IOL is the best. If the patient cannot and you have nothing else, then maybe you can go in for
He'll
an
select a toric for the patient or for himself, because she started for everybody.
So thank you so much to all the panelists, the speakers and the audience for giving your valuable time.